Yeah, I will start the ECG conference from now. And today we have a special guest, Professor Papo Chang. He will generally agree to the lecture after the ECG conference. And for the first, I will start the ECG conference today. Today's ECG is this one. Let's take a look and let's start with direction.
So I think a lot of tachycardia, heartbeat around 280, and left axis deviation, broad course complex tachycardia, which is patron is velvety patron and superior axis. So, and also there is the not related P waves in C lead to. I think it's ventricular tachycardia, and maybe origin comes from right side, and direction is affects the very zone. Maybe V5. Right. Yeah, that's it. I can say the exact origin of site.
Let's go to
It's white girls tachycardia, heart rate about over 150, and left axis deviations. And it's from the right side to the left, and the when you see the imperial leads, it's all negative, so it's from the apex to basal, and its transition zone is about the 3, 4, 5. I think like when you see the lead 2, the fifth beat is quite different from the others, so maybe that can be the fusion beat. So I think it's 3T.
So I agree with submissions so far about being broad complex, very fast, with what could be a fusion beat as the fifth one in the rhythm strip. And then there's also some notching of the QRS in V1 and V2. And there's a QRS transition from between V4 and V5. So I agree that this is likely to be a monomorphic ventricular tachycardia. Because of the transition zone being around V4, V5, I think that represents the origin of the tachycardia. So it would be somewhere along the LV and anterolateral wall. Even though in V1 the QRS is negative, so typically that would suggest an origin from the right side. But I think given the transition zone V4, V5, it may actually be from the left ventricle.
Yeah, the white girls tachycardia with apparent AV dissociation, and there's a notch in the ascending ring of V2. Is known as Josephson's sign, and it has a transition in V4, and inferior leads are negative. So and one in AVL is positive. So coming from right to left, but at the apex, likely apical part. So likely apical septum.
Any other comments from the online or the platform?
Hi, this is Hirapa. I'm glad to participate, and I'm apologize to Professor Papo Chang. I cannot see him in person. My question is there's two different opinion about the localization of BT. Copy's thoughts and what the Washington said thoughts are different. So can you tell us in detail why did you think one people from septum, the other one from anterolateral wall, please?
So I'll go first. So here we see the QRS progression. V1 and V2 are pretty much the same in amplitude, but then in V3 it's more negative, V4 is more negative, then V5 becomes positive. So there's a transition in the V4 V5 area, which suggests that may be the focus of the arrhythmia, and it's moving out from there. V4 to V5 overlies the anterolateral area, probably close to the apex, looking at where we position the ECG lead. So that was why I suggested anterolateral, but given the location on the surface, maybe it would be actually a bit apical. But also looking at V4, in V4, the intrinsic coil deflection is very sharp. So I think it's possible that, I think in V3 as well, it's also quite sharp. So I think it's possible that where it sets off is even though it's within the LV myocardium, it sits close to the conduction system. So it begins in the myocardium, shoots into the conduction system, and then utilizes that. So probably somewhere close to the His-Peckinger network within that area.
I would like to look at the intrinsic deflections in V1 and V2. They are quite broad and notched, so unlikely to be near so it's likely myocardial origin, not hypertrophy. I don't agree with that. Look at the A1 and AV, they are truly positive, so likely from right left. So that's why I localize it to more of apical, RV apical septum.
Okay, is it RV or LV? So two people shows a completely opposite opinion. So usually we look at the V1 to localize the RV or LV, as the ECG always coming from the negative wave portion to positive wave portion. But if the early transition at V1 and 2, probably it comes from septal area. But this patient, the transition is V4-5, right? So I guess this BT or SBT aberration coming from the right ventricle. And the copy mentioned about the V3-4-5, he looked for the anterolateral, but I think that is not a good way to localization because usually a V3-4-5 is localized to apical basal localization of BT focus. However, it is the reasonable for LV origin BT, not RV origin BT. So if it is RV origin BT, probably you should think more about the localization.
Dr. Paul, can you hear me?
Yes, clear.
Okay. So this patient has clearly VT. We agree. The patient has a lead 1 ABL pure R wave, and the lead 2 has a small R and QS dominant pattern, deepest S wave in lead 3. Q, and then almost the opposite imaging of lead 1. So clearly going right inferior direction to the left side toward the lead 1. Transition is relatively late in the left bundle pattern. This can be found where? This, you cannot exclude the possibility of a crux origin VT. And maybe because a septum is involved, you notice that there's a pattern break between V1, V2, and V3. See, V1 S wave is taller than, deeper than lead 2, and then V3 becomes even deeper. So there's a pattern break. There's no progression, is not normal. So typically when you see this, you cannot exclude the possibility of process known as a crux VT. So you will need to put it in that in the differential diagnosis. Okay. That might also explain why your transition is a little bit later than usual and unusual sharp notching. So those are things that probably we should discuss in differential diagnosis. Okay.
Thanks for your comment. And is there any other opinions? Or I will. I'll forward to the next slide. So this case is 86 years old male. The chest complaint was chest pain, started from 30 minutes ago, and he had a many history. He had a coronary artery disease, so he had stent at distal circum at 2050, and he also had a severe AR, MR, and TR. So he did the valve replacement. And during the valve surgery, he also did the concomitant CABG, Lima to distal LAD. And he also has hypertension, chronic kidney disease, and some other problems. And he's taking a medication, including anticoagulation and statin. And this is the EKG after the VRS, which is following the prevalent EKG. And after the DP was not stable, so the emergency department did the cardioversion, and it returned to the sinus rhythm with PVC. And this is his chest X-ray. There shows pulmonary edema and some cardiomegaly. And this is his echo report. And as you see, there is a resonant wall motion abnormality in the inferior septal area and the apex, and it was aggravated from here 50% to the 39%. And fortunately, there was no significant abnormality in the valvular function. So in this patient, the patient had the coronary angiography, and there was some abnormality in the left circumflex artery. So the patient did the stent at the far distal circum, and after the angiography, the patient has some PVCs after about 20 days, but this PVC also disappeared after the OPD follow-up. So this is the end of my presentation.
I think the difficulty for the definitely that is the VT because there is some fusion capture bit. So I think the difficulty for this one to interpret, for interpretation is due to that it is very fast VT. So a significant TR fusion. So the majority of the onset of your QRS was superimposed with your T wave. So therefore, if you look back to a long time ago, there's one criteria published also try to differentiate the VT and SVT. You use the onset of the initiation slope divided by the offset of the slope, and actually there is a discordance of your V4 and V5. Because your V4 looks like to be sharp, but your V5 looks like a slur S wave, the slur onset there. So yeah, but notching is very beautiful because the notching usually brings through for the V1 and V2. Suppose there will be some abnormal conduction even during the VT. The most interesting thing is that when you go back to the sinus region ECG, there is no obvious Q wave. Suppose that, yeah, there is no obvious Q wave, and also your VPC morphology was slightly different from your VT. But do you have the final that have mapping or any MRI study to prove the scar location? Oh.
Are we the pipeline? Within low.
I think it still belongs to something in the substrate. Just based on the entity of this case, but probably that we still need to think about that because that is a very significant TR fusion, so probably need to measure about the onset of the V1 and V2. Yeah, the V1 onset is almost superimposed with the yeah, based on this one, looks like to be right side, but it's very it have been reported, but it's very unusual for ischemic substrate comes from this area. Another possibility is that with the sometimes with the very huge septal scar, but it's not obvious from your 12 lead ECG during sinus region. So it's very uncommon that have the RV involved, even given the entity of your coronary artery disease. So I think it's very uncommon unless that is the septal scar, sometimes with the epicardial penetration to the right side. But I agree with Professor Chung Hong's comment that sometimes with the cross region involvement, but usually that we call this to be the cross caused by due to the epicardial involvement, not rather than the endocardial. But for this one, it's not wider enough. So I would like to say, if based on the entity, suppose will be something in between, but still goes probably some part goes to the endo, some part goes to epi, because the transition is too late.
Yeah, I agree with Dr. Chong. Even though this patient has a circ lesion, coronary lesion, but I'm not sure that the coronary ischemia is affects this VT. And could be affecting maintenance mechanism, but the focus is away from the coronary lesion area. But this VT happens a few days after the surgery. Am I right?
No, the surgery was about 10 years ago.
10 years ago.
Yeah, he just came from the ER with the chest pain. So this was the PCI at about 11 years, about 10 years ago, and the surgery for the valve and the cavity was about 8 years ago. And this is the, he came to the ER for the chest pain, and that's the EKG in the ER.
Okay.
Do you know about the dominance of circulation of posterior wall? Is it RCA dominant or circuit dominant?
It was RCA dominance.
Okay.
And another the points you saw the PVC rare PVC ECG during sinus rhythm. The QRS morphology quite different in the precordial lead, so it could comes from the septal area, right? But the axis of lead 2 and 3 was similar. So I think as the two professors already mentioned, so it could be coming from the septal and the axis to RB side through the moderate band or something. So there's many possibilities because this patient has significant structural heart disease and probably many the structural change of ventricle.
Okay, is there any other comment?
You know, the if you this is there's a paper published by Melchime and Matlistin about series of Crux VT ablation. Some patient EKGs, you go take a pretty similar to this what you present today. Further down from the MCB about 20 millimeter or more. So Dr. Chung discussing about that. So this is probably involve a posterior septum somewhere. And I think they classify as a Crux VT. So please review that article for you. It'll be important paper. Okay.
Thank you.
All right, gentlemen. Thank you. So wonderful conference. I see you next week.
Okay, and this is 7:53, so we will take a 7 minutes break, and we will start the lecture at 8 a.m.
I want since yesterday I just discussed with Jason, so I want to have the mixture with the two component of the slides together. So therefore I original two set of the slide was the for teaching purpose of for my fellows. So okay, so let us start that we always try to understand long time ago that we want to try to do for the VT ablation included the idiopathic one, more and more coming from the submit regions. But the most interesting thing that we have is for the SCAR VT. So the majority of the SCAR VT definitely will be the reentrant, to be either the localized reentrant. Right now we define by that. Or the macro reentrant, but never forget that this is the sarcoidosis case with the VT, sustained VT with a very slow VT. But actually, this is a very extensive scar close to the septal region with the very long stimulus to the onset of QRS. So even though that the entity was there, but you could appreciate that it's like a burst. So it's not less likely to be the reentrant, but it's more likely to be the trigger type or the automaticity caused by the disease substrate. So we start to understand the VT substrate since long time ago from the surgeons. So they just try to peel off the ischemic substrate. So this is a very beautiful paper work by the Meters and also Joseph a long time ago. They just try to peel up the scar and put the multi-electrodes over the scar area. And they could recode, initially they could recode the very late potentials here. But once if the scar was peeled off, So you could see the late potential, the underlying substrate is normal, or we could say that it's relatively normal. But you could say that once if they put the scar in and try to map it again, you could find that the late potential disappears. So it means that it's just like a proof of the ischemic substrate that have some surviving myocardial that was also PO. So this is a very beautiful demonstration from published by Rod, showing the ischemic model and the animal models with the supposed to be the channels isthmus here. The beauty of this one is that you could appreciate that is the two fixed line block supposed to be the collagens because based on understanding. And here is also a dead end here. So therefore it make a circle like this one. So when they just put the catheter here, the VT was terminated. So so I would like to say that we have several mapping strategies that we could discuss that. But for the ablation strategy that we could have an open discussion for this one, but later on I would like to have more focus on the entrainment because for all of my fellows, the entrainment usually will be the very less likely to because a lot of the doctors do the substrate modification, so we gradually forget how to do the entrainment, and a lot of people comes from the entrainment. So this is a long time ago we do an ARVC case, and a long time ago we did not have the high density mapping, so we could only use the substrate mapping. And at that time we did not have the idea of the functional substrate, so we just try to do the substrate mapping and try to adjust the voltage ratio. So you could appreciate there is the two sides looks like to be the channels. So therefore, the advantage of this one is very easy. You only need to adjust the voltage, and you could highlight the potential channels. So in this case, you could finally define the channels here by and also confirmed by the conceal and trend. So the good thing is that it's very easy. The bad thing is that so later on we could also based on the voltage mapping annotated the latent components. So we will highlight this probably to be the potential channels that we get. This is also very easy, just like what we did for the island, but it's for different purpose because you just need to annotate it that you could search for a sequence, so you will understand probably this is the potential channels. But the worst thing is that this is the two very beautiful paper, one published by Rock, showing that even you try to use this method, a lot of situation before ablation, you recorded the upstream and downstream signals. But when you try to ablate it over upstream first, actually only around 35 to 40% of the channels, when you ablated the upstream, the downstream signals disappear, which means that a lot of channels that was not communicated together. So this is also another paper published from Australia, the probably should be the Sanders group, showing that actually a lot of the channels actually is not the VT responsible. So it means that not every late potentials was meaningful. I would like to skip this one. This one is just try to highlight it. Sometimes the substrate could be useful for define the epicardial substrate. I will also want to show this the publication from Rust group showing that, and also the Bordeaux group showing that sometimes the wavefront change was associated with the presence of the scar, which means that you could only identify the substrate until that the wavefront was probably to be some wavefront comes from toward the scar and with the different direction that the scar or the late potential comes out. So this is the same study long time ago we published this. We always try to searching for the VT looks like this because this is a very easy like epicarial two-dimensional architecture. So, okay, so we move to the electroground part. So before we try to map the VT, we always need to think about how we need to set up the window. And how we set up the window, because this is not only the purpose for the FC, but we need to understand about how we need to set up for the window. So we start to work with ROS since probably 15 years ago. So we just put a color bar here. So this is the VT circuit. So we always set up to be onset because if we consider this to be reentrant VT, we would only focus on the diastolic component. However, sometimes if the VT width is wide, the QRS is wide, so that the very early potentials probably will be located at the end of your QRS. So therefore, you will miss that. So always to set up the windows starting from the onset to the onset, then you only need to take a look at the probably part of the orange color and also the yellow color and also the green color. Sorry, that's the movie. different color. Yeah, different color. Yeah, but I just put the rainbow color here. This is the rainbow color here. So actually, probably we could make the light a little bit. So you can appreciate this is the continuous fractionation signals here. So long time ago, when we try to ask the FCE to do the activation map, we always try to annotate the DVDT, the sharpest one. But probably it's wrong, because why? Because it's just like accounting for almost to be the 70% of your tachycardia cycle length, right? So if you only get one spot annotation, probably that could be the double sharp, double near field, or some part of the far field and also near field mixture together. So therefore, this is my FC helped me to make it looks like a reentrant circuit, but actually probably you already recorded. It's just like a localized reentrant. We could record the majority of the circuit cycle length within a very short period, the very small area. So that is also the pitfalls for the activation map. How to interpret this trace, this activation? It looks like chaos. Probably is have the breakout here and move out. Surrounding the area will be the outer loop and goes to this area. Why? Because you have too many components that you need to annotate it. Because you just recorded the signals within a very small area. So it's just like a localized reentrant. But if you could only localize one electroground, sometimes it could be only one very sharp potentials, could be the double near field, could be the triple near field, but you could only annotate it once, so it will confuse you as the guidance. So also the activation map, we always want to do the activation map as possible, because it's not only for interest, but sometimes if you could have the VT activation and you could terminate the VT. Actually, the VT, the monomorphic VT, just like WEW, you just try to terminate one spot and you terminate the VT with the very good outcomes. But the pitfall of the activation is sometimes you have the chaos activation. So you have no idea, just like in this case, when you just try to put the rainbow color here, actually it already belongs to the location of mid-diastolic, because the VT is relatively wide, the cycle length is long. So this potential located at the mid-diastolic. But when you try to pace, actually this belongs to the adjacent bystander. Okay, so this is also publication from Ross, the group, showing that sometimes the different mapping cascade was also associated with the different outcomes. So I would like to go to the the very important part will be the entrainment, because usually a lot of my fellows didn't get familiar with the entrain. I just saw the image from the long time ago publication from Stevenson showing that this is a criteria when we try to which brings to the VT morphology is starting with the exit. So usually this part will be the exit that brings to the VT morphology. So we are searching for disolate because it was before the onset of QRS. So therefore, we are looking at the 30 to 70% of the starting with the onset to the onset. Usually, this will be account for the center isthmus or the adjacent bystander. So therefore, we will divide, we will categorize it like just like a PPI minus TCL, and also the stimulus through the onset of QRS. But I should say that this is a very simple illustration, but this is very complex. So, okay, so this is one case that we did entrain for the ischemic VT. I would like to show that. Okay, so I just put the measurement here. So when you just try to look at this ECG, it's very funny because, okay, the stimulus to the onset of QRS is almost the same as the local EGM, because we just try to pace here, given the very high saturation thresholds. So you could see that the stimulus, the QRS to the onset of QRS, the stimulus to the onset of QRS is quite similar to the EGM to the QRS. Looks like to be concealed. But what happened to the local electrogram? You can appreciate it's very funny because if you see this one, your pacing spike start given this one. So when you see this signal to this one is less than this signal to this one, it's very unusual. However, if you look at this one signals, you can appreciate that when you measure from this one capturing and goes to this one, it's quite longer comparing to this one. The behavior is totally different from the local electrograms. So what happened to this one is that when we have the high density mapping, you have the more chance to understand about the very complex architectures. So sometimes you have the multiple site capture. We also capture adjacent bystander given a very high current pacing. So we list to this one will be part of the electrogram will be the adjacent bystander. So it needs to take longer time to returning back to the site that we recorded the adjacent bystander signals. However, we also recorded some signals, probably there will be some outer loop or some signals that was not belongs to the channel. So therefore, it will take shorter time to return back to these signals, right? So therefore, it will make this electrogram very chaos. Even that the local electrogram looks like to be very perfect, but some of these signals belongs to outer loop, some belongs to the adjacent bystander, and some belongs to the near field signals. So entrainment is good, and we always consider to the entrainment to be the gold standard for identification whether this is the true site to target. But we always also understand that the entrainment based on the animal study from elect entry showing you probably will overestimate the length of your isthmus. So okay, so we move forward to the how to do the VT mapping. So we worked with Rod several years before. We try to understand about the architecture of the VT circuit, so that we use the we call that to be simultaneous, the endo-AP mapping or the septal mapping. We try to see how to illustrate the VT circuit. So actually, that the majority of VT circuit is three-dimensional. You could probably everyone look at this paper already. So I just try to show you that even for ischemic or the non-ischemic, almost to be the 50% to 70% to be the three-dimensional architecture, which means that you could have part of the circuit involved endo, part of the circuit involved epi, or both at the same time. It's quite similar, not only for ischemic, non-ischemic, because in this article we separated the ARVC to be another category and published in our region a long time ago. So you could also appreciate that even we try to do the entrainment for a majority of the circuit, for both ischemia and non-ischemia, we have the 70% that will be only the focal breakout from both sides, which means that will be the majority will be the only the intramural circuit that we cannot identify. So so it comes from probably a lot of people already knows that this idea comes from the Rod, and the first time when I visit Europe, they told me that the lattice component is always to be the most important one. But it goes back to be a long time story. When we learned the VT ablation from Rod, he told me that not the lattice one is the most important. Because sometimes when we look at the lead potential, what brings to the lead potential? Because probably that the lead potential is late due to you have some slow conduction before. So when you have a very slow conduction before and move forward to one area that is relatively healthy or relatively rapid conduction, so the following part will be relatively late. But what brings to the slow conduction there before? You have the two possibilities. One is the line of block. One is the true very delayed component or very slow conduction. So this is a very beautiful paper published by Rod's group showing that the majority of the VT actually was terminated at the site that was not the latest based on the isochrome map. So it always located at the second or third latest part. So therefore, it brings the concept of the island map because it's relatively easy. You could appreciate that just annotated the latest one, and sometimes you have the very fractionation signals here. So it means this late potentials was late because you have previous slow conduction. So brings to this late potential. But probably this relatively healthy. Relatively healthy, not the true healthy, but it still belongs to some part of the scalp. So it means that sometimes the late is caused by your previous conduction. So I want to skip this one. So this also, they just try to publish by Aziz showing based on the island ablation, the outcome is good. And also showing that sometimes the wavefront change could also have the similar deceleration zone, which was not agreed by Gillette publication showing sometimes the different wavefront. In this study, they used the atrial right side ventricle, left side pacing, and showing the different deceleration zone. Sometimes will also responsible for different part of the circuit. So the VT circuit is also very interesting because we always, long time ago, we always consider all the VT circuit is slow. But actually the VT circuit, the two component, for the majority of the VT circuit, have the two component is relatively slow. So one part will be close to the entrance, one part will be close to the exit. So I didn't show the study, but they just try to comparing the conduction velocity. Actually, the majority of the VT, the speed was depends on the entrance and also the exit. Actually, the VT isthmus, the conduction velocity is relatively fast. So therefore, it will bring to two different parts of the morphology. The majority of the fractionation or a very slow conduction component will located at entrance or exit, which brings to this concept that the VT, the electro ground during the sinus region, probably we will also record a very fractionation signals at the true VT isthmus rather than the adjacent bystanders. Okay, so this is also another study. So therefore, it brings to the two concepts that I would like to introduce the following two publications. Is very important. Well, one is the line of block study from Rod. Another is the rotation activity. So therefore, how to brace one VT? Probably you definitely you need to have the line of block, because either that is functional or fixed line of block. So therefore, you need to have the boundary of your VT circuit. So therefore, it will look like a reentrant circuit for your VT. If that is true, during the sinus region, probably that is the fixed line of block. It means that during the sinus region, once if the wavefront propagation that was perpendicular to your line of block, so you need to circle around to the end point of your line of block, then goes to the side opposite to the line of block. So therefore, this is a very beautiful paper published by Yuki. So showing that once if you have the turnover point, that they call that to be the rotation activation pattern, the red pattern. So once if you have the rotation activity, means that you have the chance probably you are close to the line of block. So therefore, it brings to the morphology of the rotation activity pattern. So it also highlighted that sometimes if you did not have any rotation activity, it will be relatively difficult to get this kind of the successful ablation. So I think the concept is we are trying to use different methods that, but we are trying to demonstrate the same thing, is that when you have the disease substrate that you closer to the line of block, probably you will have a higher chance to close to the entrance or close to the exit. When you have the close to the entrance, close to the exit, usually that, just as what I say, that usually that part will be associated with relatively slow conduction. So therefore, you will have the more chance to have some decremental properties based on the deep map. So in this study, also showing that the deep mapping is almost the same. So so therefore, when we go back to the understanding about the VT circuit, it's just like a hyperbolic shape of your VT circuit. We always could understand part of the circuit only. But if this shape was slightly tilted or just over totally embedded inside the myocardium, so you will not appreciate that. So therefore, we could understand. Sometimes we call this the electrogram almost looks like the same, but when we try to paste from this part, actually this was dissociated with this signal. So it means that you could understand about the line of block only when it was perpendicular, the wavefront was perpendicular to the line of block. It's quite similar as the concept when we do the CTI, right? We never use the sinus region to confirm CTI was blocked. The only way that you confirm the CTI was blocked is you try to paste just opposite to the line you do ablation. So therefore, the line of block is sometimes you cannot appreciate the line of block because the wavefront was parallel to the scar. So therefore, they just try to categorize to the line of block into zero kind of situation. But it's very funny because the concept is quite similar and slightly similar to the Yuki's concept, because you have the different VT propagation pattern if you identify one line of block. But this way will be relatively closer to the red pattern, because, or this will be relatively closer to the red pattern as well as this one. But this will be different story. Why the red work? Because once if you have the line of block, so this turnover point will relatively have the slow conduction, so the VT probably will be, but this will be the outer loop. So in this kind of situation, when you do the ablation closer to the red, probably you will not get success, because unless you try to target here. But this probably will, because this is over serving as the entrance of your VT isthmus, as well as this one, because the red part is also part of the circuit. I think that the ablation strategy just depends on where you locate, just like scar homogenization published by this to be DBS. I think this is from the Luigi's publication, and also Wendy's publication. This is like a Europe worker, and also the lava emission is from the United States, and this is from Europe. So okay, I want to skip this one, but I would like to share with some about the also about the entrant. This is the teaching slides for my fellows. I already showed this one, and that is a very beautiful paper published by Tichello, showing that you get the pace mapping at this side. So therefore, when you get a very good pace mapping, so it means that you will get a higher chance to get success. If you cannot get any very good pace mapping, it means that probably you are missing something that was intramural. So I want to skip this one. Okay, so I just try to use the very good, beautiful teaching slides that sometimes that you can appreciate that these signals always try to when we try to do the entrainment, you need to understand what you are doing. So I always ask my fellows, you need to do 3 steps when you do the entrainment. The first thing, always try to measure cycle length will drive or not. If you did not drive the cycle, you don't need to do anything, just try to redo it again. The second one is confirm whether that the morphology is the same. If it's not, it's different, so you will consider that you have the manifest and then probably you are pacing the outer loop. The third part is you try to measure the PPI and also a lot of the electrogram. So, okay, so the first thing is that when you do the entrain, so if this is the circuit, if this is power circuit, of course this is less likely because this is that the starting after the onset of QRS. Okay, I pick up this electrogram as an example. If this is part of a circuit, it means that when you try to pace, then the pacing to the stimulus of the QRS should be very, very, very short. But if it brings to the long stimulus to QRS, if you really get into the circuit, so it will be relatively long, very short, because the EGM to the onset of QRS is short, right? Because this is the EGM located closer to the exit. So the only sites we call that to be the diastolic component will be located, as what I mentioned, will be the yellow part and also the green part. So in this part, actually it was located at the end of QRS, as what I mentioned, right? When your cycle length is wide, the QRS is wide and cycle length is low, you try to pace, you will lead to relatively long stimulus to your QRS. Even you are trying to pace at this electrogram, actually this electrogram is the true diastolic component rather than this one. And so therefore, when you always try to do the entrainment, you need to look at the location of EGM. Just some example that I would like to show. Okay, the EGM is close to the onset of QRS. So when you try to pace, you need to think about your stimulus to the onset of QRS should be short. If it's long, it means that you are pacing the adjacent bystander. So this is the basic concept. So sometimes when you try to pace, it leads to the next QRS, so it will be relatively long. So you need to measure to like the M+ rule from Kyoko's publication. You need to measure it. So this is the example showing relatively long. This one is only one around 165. But this is much longer, right? So it means that the stimulus to the onset of QRS is much longer than this one. So it means that you are pacing the adjacent bystander. So just like in this illustration, you have the double X for this one. Okay, I would like to show you, finally, I would like to show one. Everyone could also try to see the review the YouTube for the Ross talking about entrainment. It's a very good teaching course. So finally, I would like to show this one because this is very important, not only for VT but also for atrial tachy. So what happened to this tracing? Actually, you could also appreciate that you have the local electrogram here that was not changing in cycle length. But the first bit, the second bit leads to this morphology. So actually, this pacing terminated the tachycardia. So is this good? Actually, it's very good response. We call this to be non-global capture termination. It means that we have the local capture in. And you could also appreciate this local capture did not terminate the VT, but this local capture have the global capture, but also brings to almost with similar morphology of your tachy. However, when we look at this one, actually this is we are pacing at the side with the adjacent bystander. You could appreciate this is a 2-to-1 conduction. So the hypothesis is that we are pacing at this part. So it's just like when we pacing at the adjacent bystander, it have both the orthodromic capture and also the orthodromic have reached the ERP. So therefore did not bring to the ECG morphology and did not have the global capture. But the retrograde capture have reset the tachy, so therefore the tachycardia was terminated. So it's very, very frequent when you do the entrain not in the circuit, but also in the adjacent bystander. But even that is the adjacent bystander, suppose you are very close to the VT isthmus, because in average, the VT isthmus, the width length will be around within the 2 centimeters. So it will be relatively easier to get a termination for these kind of cases. Okay, I want to finish here.
Thank you for your beautiful lecture.
Oh.
Your lecture slide almost 100 slides. Yeah, next time.
No, this is for almost 1 year lecture for my fellow. So I speak a little bit faster, but I hope everyone could understand more about how we think about VT right now from the past and now, and also in the future, how we need to do.
Next time, I hope you give a lecture on your whole teaching style. 3 days. 3 days.
No.
3-day course. VT symposium. Yeah. Any
comment or any question?
Fellows or investors?
Dr. Chong?
Hi.
Yeah, Dr. Chong, the beautiful presentation and the wonderful lecture. I learned a lot. And I have some practical questions. During the detailed high density map, epi and endo mapping, so sometimes I think the geometry shell affects the activation pattern or reentrant pattern. So I would like to listen your thoughts about the mapping procedure, because sometimes we need to deliver the cardioversion or ICD shock, and the hemodynamic change and the depth of anesthesia also affects the geometry shell. So even everybody try to make a beautiful high density map, but practically sometimes it is not available. So I would like to listen your experience.
You mean the strategy for VT, right?
I mean the geometry. 3D geometry, yeah. Even though we can make a beautiful map, sometimes geometry, some area is not sufficient taking the points. Sometimes it's shaken by patient's move.
I think the most first of all, I think if you want to complete a very good geometry, of course, I totally agree with that. For some, we have encountered one very huge left ventricle caused by the dilated cardiomyopathy. we need to use both the antegrade and retrograde approach to reach every part of the left ventricle. But sometimes it takes time. We need to try and error, because the ventricle is totally different from the atria. So it's not smooth indeed. And another way is that I think ice is very important for the ventricle part. Not only for the substrate identification, but also you could use the eyes, always use the eyes to see whether you have a very good contact or not. For me, that I think it just needs some try and error, because there's sometimes the ventricle is not as smooth as the atria.
Yes, actually the left ventricle is most the dynamic chamber in the heart. And if I think it's better to the patient with really a huge ventricle. It's easy to map, but the patient with relatively small size endocardial cavity size, sometimes we have some difficulty map. And I have another question. The current trials of VT with cardiomyopathy, some people try to use the very simple and easygoing way. For example, the non-invasive mapping, for example, the cardiac MRI or CT wall thickness. And also the other arm is using the pulse field ablation, just the bomb in the neighbor of potential the target site. So I would like to hear your opinion regarding this easygoing way, the mapping and ablation technique.
Yeah, I think for example, like the IECG or the CT-based substrate modification. So recent publication from both those groups showing it's the efficacy is relatively comparable to the traditional way. So I think, of course, if you want to use the wall thickness, but it also depends on how many facilitate, how many methods that you have before you preparing your VT ablation. I think it's very important because we always need to think. For me, that I always probably need to plan what I want to do for this case. I think this is very important. Sometimes some patient cannot have a very clear MRI, and sometimes some patient was not allowed to receive the CT image. So if that is true, so therefore you will have lost this kind of information. As well, that I think the image information for ischemic substrate and also the non-ischemic substrate are slightly different. So therefore, we try to get all the information before the procedure as possible. For the ablation strategy, that I would like to say that the PFA looks like to be future, but we still need to think about that. Pasquale just published showing the data in Horizon this year, the late breaking showing actually we are not doing good enough right now by using the PFA, because if you look at the outcome, it's almost to be quite similar, 70% successful rate, though they use the sphere 9 as the majority of the modality for ablation. But in the future, I think that will be like the monopolar, the PFA system comes out, which was shown by Vivid Reedy last year. As what he say, it's just like a bomb. You just deliver the endo left ventricle ablation, you can reach the epi substrate homogenization. But I think it's also we also need to take account that once if you have the ones of the left ventricle is scarring, so what will you do? Sacrifice the left ventricle, just like atria, no AF. But if no ventricle, no life, right? so it's almost impossible. You try to sacrifice all the left ventricle at that time. So I think PFA just give us another alternative choice once if the patient is sick or once we cannot reach Because sometimes when you have the endocardial scar, it will become the impedance pocket. The energy will be difficult to penetrate in. So therefore, it gave us another choice that it's just like the alternative choice. We could have the energy that penetrate to deeper inside myocardium that we want to target, but it's not the final solution for all the cases because we have no idea about that. PFA still have recurrence, right?
Yeah, exactly. I fully agree with you. Based on the ABBA registry and European registry, as you mentioned, the transplantation or the ECMO rate is pretty similar to our population, not that higher. And the initial success rate is pretty good, but the 6 months recurrence was quite high. So I think we need to think about the two things. Now, number one is too much the PFA ablation make the patient fall down to the decompensated heart failure. The other one is the stunning effect. Some at the ablation procedure, it looks like the success, but some parties recovered after recovering from the stunning. And regarding the non-invasive mapping strategy, it is just for fellows. Most of the study, beautiful studies, utilizing the MRI or the CT wall thickness or ischemic cardiomyopathy. So there, we have more patients of non-ischemic cardiomyopathy. In those patients, sometimes this is just the image-guided procedure doesn't work. So that's my understanding. Anyway, thank you very much, Dr. Paul.
Thank you.
Papo, yeah.
I want to ask, there's a lot of talk about, as you said, image guided. People have come up with software like Dash 3D and InHeart. What is your experience? Do you integrate them in your VT ablation?
Yeah, we have one image guide trained in UPenn. So my colleague will always help us to reconstruct the isthmus. But when you understand about the ischemia and why the ischemia and non-ischemia are different, because if you look at the publication from Aja, the Penfield's paper showing the non-ischemic, sometimes the scar is the disease substrate is scattered. It's like not everyone is the dense scar with the very beautiful channel. So a lot of the actually sometimes that is the scattered patch-like disease substrate. So it's almost impossible for your resolution of your MRI to tell where is the scar. So that is also why a lot of the image-guided study starting from the ischemic substrate, because ischemic substrate probably will be around 70, even for some study, even higher to 90% was compatible to the dissection or the electroanatomy mapping. So I think we are EP doctors, so I think the EGM is also very important, and not only based on the image. Sometimes we also need to look at the EGM and especially for non-ischemic one is very important.
Thank you. Thank you for your beautiful lecture. Any questions or comments? Thank you. Yeah. Thank you.
Thank you all.
I would like to thank you. We are